Hello, I'm Meryl McPhee, Continence Nurse Advisor at Western Health in Melbourne and Coordinator of the National Continence Helpline, which is managed by the Continence Foundation on behalf of the Australian Government. In this video, I will focus on the most common problems clients experience with catheterisation and offer some practical solutions to be given or followed up by health professionals. It is very important to ensure that there is a clear and detailed catheter care plan for clients to ensure good ongoing management. The indications for catheter use include short-term following surgery for drainage pre and post-operation, long-term following surgery for retention of urine for prostatic issues and management of bladder problems related to conditions such as stroke and multiple sclerosis. Intractable incontinence, that is, bladder problems which have not responded well to treatment and therefore cannot be cured, for example, spinal patients who are unable to empty their bladder. Catheterisation might be considered beneficial to enhancing a person's lifestyle or quality of life. Catheters can be indwelling or suprapubic, latex, non-latex, short or long-term, and available for males, females, and paediatric clients. There are 3 different sizes of balloons: 5 ml for paediatric clients, 5 to 10 ml for routine drainage, and 30 ml for post-operative use. Sterile water is used to fill the balloons, and the amount put in the balloon should not exceed the recommended amount. Everyday advice given to patients as part of their catheter care plan should include good hygiene, particularly to the area around the catheter where the catheter enters the body. The area should be washed at least twice per day with mild soap and water, and men should wash under the foreskin. Patients should be advised to have a fluid intake of 1.5 to 2 litres per day, which is equivalent to 6 to 8 cups of a variety of fluids, including water. Remember that soups, jellies, and other similar foods should be counted in fluid intake. Patients should also keep their bowel patterns regular to avoid constipation, avoid kinks or clamps on the catheter, empty the drainage bag regularly. Keep a closed system, which I will talk about later in this video. A day bag should remain in place for 7 days and then be discarded. It should only be changed more frequently if stained or smelly due to sedimentation. A night bag attached to day bag might be washed out with warm soapy water every morning. Use the night bag for 2 weeks and then throw it away. Patients should call the doctor or clinic for assistance if they experience any of the following problems: the indwelling catheter or suprapubic catheter blocks, there is no urine in the bag for 2 to 3 hours, the indwelling catheter or suprapubic catheter falls out, the patient experiences abdominal pain, urine is suddenly blood-stained, if there is bypassing or cloudy urine. How often a catheter should be changed depends on how the patient reacts to the catheter, and this varies with each individual. It is important that the catheter is not left in for longer than the manufacturer's recommendation for changing and is changed in accordance with the catheter care plan. Regular changing will also reduce problems due to encrustation on the balloon or difficulty in deflating the balloon. Encrustation can be a problem in certain patients. It is usually possible to estimate the lifespan of a catheter by observation and recording the length of time that the catheter remains functional before becoming blocked. Documenting how the catheter is draining assists in scheduling recatheterisation to take place before blockage occurs. Research shows that when a catheter is put in, there is bacteria in the urine after 14 days. In order to minimise problems, symptoms of infection should be monitored and managed appropriately. Antibiotics should only be prescribed if the client is symptomatic, for example, experiencing symptoms of pyrexia, loin pain, offensive cloudy urine, or confusion if not normally confused. Most sedimentation is produced by bacteria which makes the urine alkaline, for example, Klebsiella and Pseudomonas. Urethral discomfort may be caused by distension of the urethra by using too large a catheter, which may lead to urethritis and offensive discharge around the catheter. The solution is to use a different type or smaller catheter. Maintaining a closed system is important in reducing the infection rate. A closed system of urine drainage is where the catheter and collection device are one continuous system. Drainage and emptying of the catheter should be achieved without disconnecting the catheter from the bag. An increasingly popular alternative to the cumbersome and sometimes unsightly drainage bags is the use of a catheter valve, which is a tap-like device that fits onto the catheter instead of using a drainage bag. Patients need to be assessed as having the necessary awareness, dexterity, bladder capacity and sensation in order to learn how to manage the use of a valve. The valve allows the bladder to fill and empty, mimicking normal bladder function while a closed system is maintained. Another common problem is blockage of the drainage system, which can be caused by the indwelling catheter or tubing being kinked. The bag itself may be hanging too high. The bag should be below the height of the bladder at all times. If the urine bag is too full, urine will not drain. Constipation may also prevent a catheter from draining. If none of these are considered a problem, then this may necessitate the need for the indwelling catheter to be changed. Bypassing is leakage around the catheter. This might indicate that the catheter is blocked, or it could be caused by spasm in an unstable or irritable bladder. Constipation, lack of fluid intake and urinary tract infection should be excluded or treated. If the bypassing is being caused by spasm in an unstable or irritable bladder, then sometimes choosing a smaller catheter with a smaller balloon can overcome the bypassing problem. Replacing the catheter does not necessarily address the underlying cause and may exacerbate the problem. In some clients, anticholinergic drugs can help reduce irritability and bladder spasm. Hematuria is the microscopic presence of blood in the urine and is quite common in the urine of catheterised patients and may be a result of the trauma of the catheter being inserted or from infection. If the bleeding becomes severe, seek medical advice. Macroscopic bleeding, which is the visual presence of blood in the urine, is seen in tubing or bags on occasion. If there is a marked amount of bleeding, then it should be reported and investigated. If the client has a urinary tract infection, it is recommended that the catheter be changed after the client has been taking antibiotics for 2 to 3 days. This will reduce the likelihood of ongoing or recurrent infection. If you need further information on any of the problems mentioned in this video, call the National Continence Helpline on 1800 33 0066. The free helpline is staffed from 8 AM till 8 PM, Monday to Friday, by continence nurse advisors who provide advice, resources and referrals to local continence services. The helpline is also able to provide you with information on available funding schemes for patients to purchase catheters. Once again, I would like to reinforce that a clear and detailed catheter care plan is vital for good ongoing management. Thank you for taking the time to view this educational video.